So, dear Professor Muruzaki, I'm very pleased and honored to be here. I thank the organizing team to invite me and for all the hospitality I experience in this country. I'm extremely grateful. You see on my first slide, you see Berlin, my home city, and your Mount Fuji, and I wish I could see from us directly to Japan. You also see I recently was asked to write an article about responsible resource management by Professor Abula Kumaran for his journal, and I got to read the literature of Donald Berwick, who is the director of the Improvement Health Institute under Obama, and he defined that there are three aims in medicine. One is the patient satisfaction of the individual, the health of the population, but also the cost reduction. So when we introduce new methods, we should think of all these three games. I have to disclose interests. You see me here as a young researcher, and these are my parents and my sister. So I got in touch already with Pessary's at that time. And you can see my father made in his home pastries for his patients, and I played with my dolls with them. So I have a very long hands-on training course behind me. But I was forbidden to apply these things when I started academic medicine with Professor Hansmann and Saarling, and I did ultrasound and all the high-tech stuff. Only when I went to Holland, when I was already running a big center there for high-risk pregnancies and worked from day to night, I could do what I wanted. And out of despair, when my parents were already dead, I was confronted with a situation where I had no choice to use a pessary from home. And it was successful, and then I tried this more, and I was encouraged to use it, but no company would make it. So I asked the handicapped, brain-damaged people of our hospital to bake it for me, and you see here the international team. And later, when I had the first case control study published, my friends from the international scenery took it over. Well, due to this history, I was already confronted with Japanese perinatal researchers and neonatal researchers like the admirable Dr. Nashida, who made it really possible that Japan became the leading country with the lowest survival rates of small for date preterms. And you see here the rate of early and later infant death below 1 week, 4 weeks, and 1 year. And it was lowest in Japan and at that time and highest in the States, which shows that the money you invest in country is not everything. And here you see also the obstetricians, they did very well in the country. So you can be proud. And when you see over time how all these mortalities have decreased, we must still be aware in global views that some countries nowadays are here where we have been in the 1950s. And when you see this is a Lancet paper, but also a very new paper, recent paper from this year comparing prematurity rates in Europe, you see that the poor country of Lithuania had the lowest rate, but Hungary had more than 2 times the rate of preterm births. And again, Japan is doing very well in terms of absolute numbers of deaths or in terms of the rates of preterm birth compared to the population, which is highest in 10 countries which are very poor, mostly sub-Saharan, and in absolute number, of course, in India. But here in Malawi, the rate is nearly 20%. So this also says it all, that it is a lot of factors which influence the rate, and this is a citation of Professor Nishida, whom I really adored. It is not technology or scientific knowledge alone, but also the mind and heart of caregivers and their confidence based on experience and learning and their trust in mothers. So when I was younger, I wouldn't have dared to say that. But nowadays, I become a bit older, and I think it's a lot of care what we have to apply and not only techniques. And when we look in history, we have Hippocrates, who was the father of science, but we also have Sextus Empiricus. He only believed what he did, what he saw, and in experience. But I think when you want to do good evidence-based medicine here, David Sackett, you must combine this. And the man I admired most in all the doctors I had known when I was young was Emil Papiernik, who really reached, like Professor Newman had shown yesterday, that a whole population around Paris had a reduction of preterm birth, and he was a very cultured and kind character in addition. And we know Professor Romero, who first defined the preterm birth syndrome. Well, I had already a PhD when I was a student, and also papers about ultrasound, and I was the first woman to be admitted in Heidelberg University. It sounds so great, but my life was very tough. So the first stress test I was confronted with was that Professor Kubli, who was the boss, asked me to write book chapters for him. And I was really sitting at home crying because that I was 25 years, a bit too much for me. Anyhow, I tried my best, and you see, even I was influenced by some art pictures. Even at that time, I painted in my picture progesterone, and because I knew the pessary from home, I also showed a picture of the pessary of my father, though I was never used or allowed to use it, and I said that the cervical opening is the tip of the iceberg. And now when I look back at this article, I think for this young lady, it was not so stupid. Then I was also, I got to know Professor Romero. He developed the concept of preterm birth syndrome, and mainly at that time of the factors of three complexes like uterine contraction and overdistension, but also the whole story with membrane activation and infection. But it all finally comes to cervical ripening, and you see that the collagen bundles will dissolve, and there are a lot of biochemical mechanisms involved. And now he published similar stuff in Science only some years ago, and the things have not really changed since then, only he showed this picture that there are a lot of multifactorial influences like stress, overdistension, infection. And we cannot approach them all, but some of them are approached by the methods we use. And then we have the concept of Papiernik, of primary and secondary and tertiary prevention. And I briefly want to remind two important measures of primary prevention, that is the stop of smoking. We have heard that in Australia they can even phone, I was impressed, day and night when they want to stop smoking. But there's a very recent European study also showing that the strictness of our legislation towards tobacco control has a very big impact, not what you would expect on low birth rate, but much more on preterm birth rate. And the odd ratio in comparison to countries of strict and very poor restrictions was 10. So you can really reach a lot when you compare these countries. Another reason for Japan, which might be a reason why you have lower rates than other countries, is a good diet. So this was also a study comparing different Western food and showing that when you eat a lot of vegetables and meat, this might have a primary impact of the whole population. And when we now speak about secondary prevention, we must also think of something so old-fashioned as a history of a patient. Although we know it only contributes to 30%, but it should determine the intervals, how frequently we see a patient. So we know this study is a big meta-analysis, finally including more than 6,000 patients, showing that people after artificial reproductive techniques have a higher preterm birth rate below 37, but also below 34 weeks. So in these patients, we should see them earlier, we should be more sensitive. But also, this is a study I did still in Holland. It's not yet published, but it was presented at the SMFM. The earlier a woman had a preterm birth in her history, the more rapidly the cervix shortens. So be attentive. And of course, the cervix is not so long in the focus of our interest as a secondary diagnostic tool. It was even when I was already specialized, when the first papers came out by Anderson and mainly then of Imes, showing that the shortening is correlated with the duration of pregnancy. And before, in this art pictures, you don't even see the cervix, and only 100 years ago it was defined clinically as a possible detector of preterm birth. And there are more modern papers now in seminars, I can recommend this, of perinatology, showing that there is also a smooth muscle in the cervix and these in the internal os, and they can also modulate the tissue, the extracellular tissue of the collagen in the cervix. And when you have more pressure on the cervix, then the cervical cells produce increasing interleukins. And you can also look at the mucus of the cervix. It is very important to know, and I'm getting sometimes mad that you use strict cutoff values for the cervix, although the cervix physiologically shortens during gestation. So this is a very intelligent analysis, although it's old, from Honest, showing that when you have the same cutoff value using before, here it is in twins, 20 weeks, the odd ratio, the likelihood ratio for preterm birth is before 34 weeks is 60, and the same cutoff value only 4 weeks later is only 4, and whether you have contractions or not, it does not matter. So this picture should show us that we should look at that time. And what is also important to know, what happens when we implement cervical screening. This is a paper from the States from this year showing that when you screen in non-risk patients, you can lower the preterm birth rates. But this is a study from Canada showing that there is still, although we know all these transvaginal sonography screening methods and that it shows as a risk, that only in about half of the patients the doctors reacted to these signs and were transferring the patients. And therefore, again, I liked so much what Professor Newham had presented yesterday. Well, already in the 1997, I published a paper that the cervix is dynamic and that when a woman stands, and I kept this video from that time, now the woman stands up, and you see that when she stands up, you get a shortening, you get membrane dissociation, and even the fetus here is getting nervous from inside. And when this happens in working woman every day, you can imagine that she probably would have more risk when you don't hold the cervix to get premature rupture of membranes. And again, I was happy now to see on the SMFM that this cervical stretch and dynamic cervix triggers also interleukins. And I could also publish in the White Journal that diagnosis in the standing position was the most significant predictor of preterm birth in singletons and twins. We meanwhile also can have online detection of the uterocervical angle, and this combination of cervical length and the angle has a better prediction of later preterm birth, so we use them both. And of course, you also have biochemical markers of preterm birth. The ACOG does not recommend screening with fibronectin, but at least you can do reassurance when fibronectin is negative. You know that she will not be delivering soon. And you can even, for short-term prediction, do breathing detection of breathing movements, which also signifies when they stop that the woman might deliver soon. And I don't go into details here, but we might have an image of the future that when you look at these papers with 70 authors, meanwhile, about genetic markers of preterm birth, that it might be a future then to base individualized medicine. But I cannot imagine this for India, Africa in the next future. So for me, it's still modern art and not medicine. I now have to compare the conventional methods which are used to prevent secondarily, when we have already detected a risk, preterm birth. And the classy one is the vaginal cerclage. And it was done in every 10th woman in Germany at a certain time, because we were thinking not only that it would help, but it would also bring quite a lot of money to the obstetricians. And in the times of evidence-based medicine, it was clear that prophylactic cerclage does not work, neither in twins nor in singletons. And it also came clear that in singletons, and that is the most recent Cochrane review of Alfirovic, that in comparison with no treatment, cerclage reduces the incidence of preterm birth only in women with recurrent preterm birth, so when she has already a history with preterm birth, but there is no significant reduction in perinatal mortality or neonatal morbidity and uncertain long-term impact. And cesarean delivery increases. Well, this is also a meta-analysis of a series of Bergella showing that in these women with 5 studies who have a risk of preterm birth and short cervix, then it might work. And we have the real rescue cerclage when a woman comes with already ballooning or dilatation of the cervix until 10 centimeters. And there are no randomized trials, and I wouldn't recommend them, but it can, out of despair, be helpful when you put a Foley catheter and when you really supervise well that you exclude infection, because she can also get sepsis even with a negative amniocentesis. In twins, cerclage is critical. Confirm the literature. The first meta-analysis of Bergella even showed that the preterm birth rates increased, and also the most recent meta-analysis, Cochrane by Raphael, showed that low birth weight, very low birth weight, and respiratory distress syndrome increase when you put cerclage in twins. However, there is a very new study now in the Black Journal from Adams showing that there was no difference in the rate of preterm births in twins when they put on a sonographic shortening of the cervix cerclage, but there was some benefit in women with a cervix below 15 millimeters. So we have to consider, and I'm really very, very disappointed in many studies, that cerclage is not cerclage, and the cerclage is operator dependent. It has been shown by Scheib that when you do 18, the thread not 18 millimeters away from the external os, that then your success rates will be much worse. And so what I miss in the studies is really a control how well the procedure was performed. And we have also to remember that there is a possibility to do an abdominal cerclage, and I think this is make sense in desperate cases where you surely cannot place a Pessary or progesterone because the patients have no cervix after trachelectomy or several conizations. And I did several ones in Holland, and I did recently an abdominal cerclage also in a twin pregnancy. You see here the pictures, and the pregnancy went fine until 34 weeks, until she got preeclampsia. But I operated again there. You need eminences. I always operated with Professor Lottring, who has done hundreds of patients, and I wouldn't dare to do this alone, because I want, of course, for these desperate patients, that the best operator is performing the procedure. And I doubt in many studies concerning twin delivery, cerclage, or whatsoever, that was controlled. And we are also doctors and not only statisticians. Well, this is only to keep in mind. Of course, the situation is different when you take drugs. Then you have to care for a good relationship with your patient, that the compliance is good. And also the compliance was not always controlled in studies. But it more depends on the patient. Well, related to progestogens, there are natural progesterone, and there is 17-alpha-hydroxyprogesterone capronate, which is applied intramuscularly because the lifetime is longer. And this is an artificial product. And progesterone was already proposed by Papiernik to be effective. And that is also shown by mice, but it's also dependent, the alpha-hydroxycarbonate, from the pharmacogenetics. I don't go into details, and therefore it may be variably effective. Well, progesterone came in the focus after the study of Nicolaides and Fonseca, and they could show that in patients with a cervix below 15 millimeters it was effective, but had no effect, even not in the most recent Italian study, after an episode of premature contractions. Then Hassan and Romero published their study, and they looked at patients with a cervix between 10 and 20 millimeters and found an effect of progesterone to reduce preterm birth, and this was the first meta-analysis in Singletons of Romero showing the effect in reducing preterm birth before 34 weeks and lower. But then there was a shock for the whole group of progesterone fans, because the Optimum trial of Jane Norman could not show this effect. They had the largest number of patients, but also based on fibronectin and history. And more importantly, they could, and this is a good argument, they could never prove an effect on long-term outcome. But again, Professor Romero published a meta-analysis in Singletons, even including the study, and saying that there was still an effect to reduce preterm birth. But in twin pregnancies, a lot of studies, either with short cervix or preventively, have not shown an effect, but a big meta-analysis of Schrout showed that there might be a possible reduction in patients with a short cervix, but the situation is still conflicting. When you look at the most recent meta-analysis of Romero integrating a very poor study from Egypt, not placebo-controlled, not registered, then this study made a meta-analysis positive, whereas the Cochrane database says it's not effective in twins. And when you look at the third meta-analysis of Romero in Singletons, you see even more effect, even to prolong pregnancy before 37 weeks. But you see also that it does not work in PLEX, it does not work in Asian women, it does not work in obese women. So look also at the numbers, and fair enough, he gave very bad marks to Jane Norman's study, not considering that the study of Fonseca was registered after it was finished. When you look at the British people, they have other criteria to include in the meta-analysis, and when you exclude studies which were not registered and not placebo-controlled, they come to the conclusion that progesterone is not effective. So it's very difficult, and even more confusing that Professor Thornton sent me this FDA link, and the FDA analyzed the data of Hassan again, and they said it had no effect and the long-term outcome was negative. So it's a bit for innocent people to read that, well, you cannot do much harm, but it's sometimes you realize that retrospective meta-analysis can be tricky. Well, we come to the pessary. The pessary is not a ring. It is a kind of a copula which imitates the vaginal vault, so that the inner ring, which constricts the internal os, comes as high as possible, and then it rotates. And this picture of Hieronymus Bosch dates from 1480 and shows that some angels and something like that. And so, because I put the profit of my team to my angel foundation, I think this is nice. And the reason why I used the pessary was a patient when I worked in Holland who came, and she had lost already two babies at 20 weeks, singletons. She had now a twin, and she had a cerclage. The cerclage was ruptured, and she had funneling to the stitch, so you didn't want to push this up and stitch again. So I remembered this pessary from my father. I said to her, listen, I can give it. I don't know what it helps, but I have no other option. And I left her at home. I saw her weekly, and she delivered at 36 plus 2 weeks. I got these shoes with angels painted by herself from each child, and I was very touched, and I still keep this as my biggest treasure. And then I repeated this, and then I published a case-control study, both in twins and singletons, suggesting with a question that it might have an effect, and asking for others to do a randomized controlled trial. Well, people asked me, why should it work? And my friends in Brussels did this MRI study in twins who were lasered anyhow, and they showed that really the uterus-cervical angle is changing and funneling is disappearing after the application of the pessary. It might also be because you can see the cervical plug, that the cervical plug is more conserved, and you might reduce thereby sending infection. And even when you have more discharge, this does not mean because that it is infection of the uterus, because Romero has shown that the microbiome of the vagina does not correlate with preterm birth rate. I also think that it's very important to reassure your patients. They are stressed, and you must take away their stress. You must also be an experienced clinician to apply the pessary, because also not to apply a pessary, when a patient comes in with sludge, there are now people who apply pessary, then it doesn't work, and then it's, of course you don't apply a pessary in this situation. I give indomethacin and I wait, and when the picture is like that, then I might consider it. But when you do it, you frequently see kind of restoration of the cervix, but I also explain that when she takes the pessary, and that is based on the first Cochrane database, and I work with Max Planck how to introduce different methods to patients, that she needed much less tocolytic treatment, much less corticosteroids. This is proven by the Goya study. And that these, even for patients who cannot read, would be the patients who deliver preterm without pessary and these with pessary. So I can convince even aboriginal with these balls, maybe. We also saw in the first randomized controlled trial of Goya and the Spanish team, whom I taught clinically and who controlled took their patients, that there was a reduction of poor composite neonatal outcome, but also of sepsis. And then Ben Willemol did the first study, or supervised the first study in Holland, in twins, and in those twins with a short cervix, and they did the good thing to apply the pessary before 20 weeks, between 16, and I think this was the secret of his success, though the teaching was also not brilliant. And the death rate before discharge was 6 times higher in the expectant management group compared to the pessary group. So this was also presented at the SMFM, published in the Lancet, and thereafter the Spanish team also published that you could reduce preterm birth in twins, but that they, I think, had less success on the neonatal outcome because they applied it schematically too late, between 20 and 24 weeks. For my taste, too late in twins. There was a nice abstract at Fetal Medicine Foundation World Congress showing that there's a learning curve and that the success rate within one team is different between the first 2 years they used the pessary and the second year. So in the first 2 years, these patients delivered at 34 weeks and then at 37 weeks. So you need some training and teaching or some confidence. And then we have the negative trials again from Professor Kypros Nikolaidis, as well in Singletons, published in the New England Journal, and in twins, published in the American Journal. And both studies were hardly criticized by the Goya team. And amazingly, on the cover of the American Journal, as you can see, of where they presented the studies, where Romero is the editor and Kypros Nikolaidis knows everything about perinatal medicine, they placed the pessary upside down. So imagine Brunelleschi building the cupola like that. The dome would have probably have collapsed. So I think when you distribute pessaries around the world and have never placed a pessary yourself, and you don't give a protocol and you don't control that, what they are doing, because they are sending patients away, the results are, of course, different as when you do it in a close team. And even Professor Nikolaidis admitted, we acknowledge, that there was a limitation, that many doctors were involved who did not receive supervised training, and it was not sure whether the insertion was appropriate, and that is why the European guidelines now recommend a training course before you start with pessary treatment, but this also holds true for a lot of other maneuvers, also for cerclage, and it also fits with a statement of Nikolaidis himself from earlier years. Caregivers should be trained and their results should be supervised to external quality assurance. That was not the case clinically with the Nikolaidis trial. There's now also the first long-term follow-up after pessary and from the Preterm trial, and it shows that in the pessary group there was a longer, there was a significant higher number of intact survival. They all had a Bailey score after 3 years. And the number to treat to prevent cerebral palsy or death in twins of the pessary was 1 in 6, and I think this number is not too bad. There were no clinically relevant differences in cognitive, language, and motor effects. There is now, only published a week ago, a paper of the Spanish group, Cervical Pessary to Reduce Preterm Birth after an episode of preterm birth, of contractions, and they could only reach a significant difference in deliveries below 37 weeks, but the recurrence rates were reduced, corticosteroids and tocolytic rates were reduced, and they think it makes sense because in no measure up to now they have proven that, but I know that the Dutch have negative results, and of course, again, I have seen patients with bleeding and contractions, and they were put into a randomized study because you get money for randomization in Holland. And of course, I would never do this. I mean, there is a difference between contractions and contractions, but when a woman has bleeding and when she is nearly delivering, we shouldn't put her in a randomized study of this group. Well, because I was confused, we used the Pessary, and after the Hassan study, we used both Pessary plus progesterone, and I let my research students analyze the data, and they are published in the American Journal. We compared Pessary versus Pessary and progesterone. There were no significant differences, but there was a shorter neonatal admission time, which might have been due to the historic cohort, but I don't know. But if you realize, I always use percentiles. These are the plots of the cervical measurements, and you see that measurement which is pathological at 16 weeks can be totally normal at 25 weeks. So I use this, and I see when risk patients cross centiles, then I already treat. And you see from the Kaplan-Meier curve that there was no difference between Pessary or Pessary plus progesterone, neither in the risk group nor in the screening group. Sarkone did just the opposite, published in JAMA in December. He applied the Pessary on top of patients who had progesterone, and there were significant differences in the rate of preterm birth in favor of Pessary plus progesterone versus progesterone alone. Also, NICU admission and composite neonatal outcome was improved with a combination. And last not least, the best comparison in twins was now presented at the SMFM. This was done under supervision of Ben Villemol in Vietnam, and they have 1,000 twin deliveries a year, and the Pessaries were applied by experts for the studies. And this is the group with long cervix below 38 millimeters, and this is a predefined, pre-registered subgroup with cervical length below 28 millimeters, which is for Asian women, the 25th centile. And again, they randomized early and applied the Pessary early. So in this group, let's look at the short cervical length group. Here you have also significant differences, but they were more striking in this group. Delivery below 34 weeks was 20 compared to 44 with progesterone. Delivery below 37 was 46 compared to 72 with progesterone. But look at neonatal sepsis, 6.7 in the Pessary group and 24% in the vaginal progesterone group. And when I remember my teachers who told me that the Pessary would induce sepsis and infection because they see the discharge, I now think they should look at this data, and the truth is different. And when you imagine what suffering you can prevent, that also the admission rates to the NICU were 15 compared to 44, then you know that the effort to do this is in comparison with the outcome or follows the triple aim I have talked about. Well, I think the audit which Professor Nikolaidis introduced in ultrasound was great, but we should also do it in clinical medicine. And even more important for me, and I will put all my effort in the next years, is to implement patients, to care for them, dare to care for them, to teach the teachers, but this is the hardest. Our teachers in Germany are very arrogant, and they are not used to be taught, and they know everything, although they don't. So I have given up. I rather want to approach the patients directly by apps, by this wonderful cooperation with Max Planck, but not only on cervical length and preterm birth, also on the non-communicable diseases, and mainly on anxiety and stress caused by us doctors. I shortly want to show, because I was asked to here in Japan about tertiary prevention by antibiotics and tocolytics. Well, I heard yesterday that it might be positive to treat bacterial vaginosis, but the most recent study in France showed that there was, even in a Nugent score above 7 treated with clindamycin, no significant difference, only side effects in the treatment group. We know when we treat women with intact membranes from the Oracle trial that the number to harm them and for cerebral palsy was defined as 1 in 64. So we cannot treat a microbiome which is physiological in the vagina, and we should not. And this is a very recent study also from the neonatal side. We produce neck and resistance in the children. So we should be extremely, and Kypros Nicolaides in his New England study treated 40% of patients only due to stupid discharge with antibiotics. We also should not waste tocolytic treatment. It has been shown that it is no outcome to prolonged pregnancy improvement for 2 days. It only helps us to give corticosteroids, which can also do harm. In this study, which was also cited yesterday, it was shown that calcium channel blockers and prostaglandin inhibitors are better than ritutrine and better mimetics. But my resident, Caroline Rose, with benvilamol, did a randomized study to prolong calcium channel blockers and gave alternatively placebo, and there was really no single difference. Only you risk that you get bradycardia by calcium channel blockers. So even worse, Roberto Romero published a study about atosiban. When you apply tocolytic treatment in very early pregnancy, where the rate of microbial invasion is very high, you risk a higher rate of intrauterine death. The intrauterine death rate below 26 weeks with placebo was 0. With atosiban, it was 37. So please be cautious with antibiotics and tocolytics, mainly when you prolong them. The future, and I think much less biased much less sensitive to bias, are prospective meta-analyses, where you define in advance which studies you implement. It needs a long network, but I'm extremely grateful to Professor Sade and also Professor Moll, who introduced the prospective meta-analysis for Pessary trials. It is guided by the NIH. They use the Crown outcome parameters, and the Vietnamese study will be the first which goes into this whole data network. And with this project, I think that a sentence comes true, which I defined with Alfiro, which we all agree, and that's why we share now our knowledge. We all agree that the best answers to clinical problems will come from international collaboration, and whether we can all speak with one voice, one time will tell. I think we can speak with other people from other nations. I can speak very well, but I have difficulties with big egos wherever they are. Well, we have to reduce controversies and include experienced clinicians. This is not any longer fashionable. Many of the trialists behave like statisticians. They sit at the table and they never see a patient. And there is also an overload of meta-analysis. If you put in PubMed Bergella and meta-analysis, you end up with 75, and I have doubts whether he knows all the things he does meta-analysis about. This is to produce papers, but I don't know. And I have summarized this in this paper. But still, this prospective analysis, but even more the implementation study, what Professor Newman knew, he was in the room. I think, what do you want to know? That is what Professor Papiernik did, what we did. You want to improve. Think of Mr. Berwick, the individualized satisfaction, but also not only the randomized trial population, but in your own region you want to improve medicine. So I think these studies are much more human and much more honest. We should think in global perspective, and we should know that in our countries, mainly in the US, you can care for these very early preterms, but in a lot of countries where they have these high numbers, they don't have the money to have neonatal intensive care. They have not even the money to care for the woman. So we have also to think of methods which we can teach to healthcare workers and which might improve something. But we should also keep in mind that maternal stress accounts for 70% of the variance in childhood cognitive abilities, and not only preterm birth, and that we have not to worry our mothers too much. We have really to reassure her even when we inside are afraid. And I don't see this in our societies any longer. And I think it's very important. And that is also now I come to the end where I want to work in the future. I had a dream, of course, because I cried as a young student when I saw preterm babies die. I wanted to do something, and I had a dream to do something. And I still see too many babies, preterm births, dying. But everybody at his little corner can do a little thing. And what comforts me also is that a lot of famous people were born preterm, and they have contributed to the culture of our mankind. And when I'm in Russia, and I travel, I like traveling, and this is from the Tretnakov Gallery, Gabriel announcing pregnancy. There's no artist mentioned. And the guy told me at that time it was not possible to mention yourself as an artist because you had a vision of the future. You wanted to dedicate this to mankind. And I wish that the ego of our doctors should also be a bit less. And then I think the work would be much better. And we can, when we imply these old medical values, even with modern techniques, and you see here Angela Merkel in Japan, admiring your technique, you can combine this like Mr. Mishida did. I finish with music. I heard from my chairman that he was in Berlin and he couldn't see the Berlin Philharmonics. I cared for Magdalena Kuchina, who is the female, the wife of Sir Edel, and she played with my friend Reinhard Goebel. And this song, what you hear, she played throughout, or she gave concert, pregnancy. And one of my hobbies is really to do stress reduction in pregnant women, to implement music, because health is understood as the physical, mental, and social well-being that goes further than just the absence of suffering. And here you see the German society, German-Japanese society singing. They have their own choir. And I hope one day you come to Berlin and we can go to a concert. And maybe when I come again to Japan, you are better than me in pastries, but I present you with music balls for pregnant women and some nice concepts to improve life quality of pregnancy. Thank you.